Welcome everyone to today's program. I am Emily Rapley with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenter. Robert Zaza is the founding and managing partner of ASC Management. ASC Management develops and manages ambulatory surgery centers for physician groups and hospital physician partnerships. With a focus on managing the business and operations, ASC Management maximizes ASC performance, revenue, and profits. Since 1986, ASC Management has provided expertise in turnarounds, joint ventures, and strategies for growth. It is now my pleasure to turn over the floor to Robert to begin today's presentation.
Emily, thank you so much. Thank you all for joining the webinar today. It's April Fool's Day, and I'm not going to try to make a fool of myself, but I'm trying to share my best thoughts on this topic after having done joint ventures and development and management of surgery centers on over about 200 centers since 1977. I was at the Oxner Clinic, a group practice, and we decided that Dr. Reed in Phoenix had developed a very good model and went over there to see it. And in the clinic, we did a joint venture in 1977 with Oxner Hospital. And it was a very little one-room center, but very successful. And since then, we've done a number of them. So today's purpose is to share with you some thoughts basically on issues that we commonly come across doing a lot of joint ventures. 75% of our centers are joint ventured with hospitals and or physician groups. They're a little bit different for each center. As you're taking notes during the webinar, I will be taking questions at the end. But I wanted to start with the first tenet of this. One thing in common with all joint ventures is they're all different. The joint ventures take on characteristics of the institutions and physicians that are involved, the market in which they're located, and the physicians and hospitals' desire of why they wanted the joint venture in the first place. The joint ventures are formed typically because some doctors, A, want a break from hospital to control their own operating room experience, patient flow, and make some return on their skills and efforts. They also want to link up with large health systems and not to be left out. And some want to be more attractive to payers, ACOs that are forming, workers' comp carriers, and large self-insured employers via their TPAs, third-party administrators, or direct contracting, which is becoming more popular again as it was in the 80s. On the other hand, some hospitals want to bond with their physicians to have closer partnerships and relationships, or bond with their physicians to prevent them from aligning with another health system, or to integrate their services more vertically, offering a wider range of services. The point is that there are various reasons why JVs are formed, but with these differences, there are common lessons that carry over to all the joint ventures. Some of these lessons may sound like common sense, but many times they are skipped in the process or left out of the process. So let's examine the 7 lessons that I've learned of the most healthy joint ventures. Next slide, please. Next slide. The foundation of a healthy partnership is trust and respect from all parties, hospitals, the physicians, the ASC management company, or the person helping to develop the partnership, whoever that is. All bring unique and valuable experiences and expertise to the joint venture. We need to value and respect the differences and unique contributions that each one brings, each party brings. And we really all need to listen and not impose preconceived ideas on these processes to make it a true partnership. Many times there are a lot of preconceived notions of what the partnership should be, how they should be run, etc. And that needs to get really discussed on the front end, which we'll go into in a moment. Next slide, please. The hospitals that have the most successful and healthiest joint ventures acknowledge that they really don't know the ASC business. Coming out of a large nonprofit hospital and a large for-profit hospital being COO, I was amazed at the difference between surgery centers, ambulatory care, and running a hospital. You need to understand the differences. It's really a different animal. It's a small business. These typically do $5 million a year to $10 million a year, depending upon the size of the center. It's really small business administration. And it's really, we don't want to replicate the hospital systems and lay that on top of a lower cost and lower reimbursed delivery system. So we really need to understand that it is a different business, although it's healthcare. There are operating rooms like we have in the hospitals. There are recovery rooms. There are nurses, etc. But there are really unique aspects to this business. Likewise, the ASC management group or persons that are working on developing the joint venture need to show their expertise on the front end and to all, particularly in revenue production, physician recruiting, cost savings that can be done through supplies and implant, drugs, insurance, employee benefit, and purchase services, all of which we do, all the centers, all the management companies do on a large-scale basis, particularly ours. We have about 30 centers right now, and we buy a lot of supplies, but a very narrow range of supplies with a lot of volume for 30 centers. So oftentimes, and most often, we buy cheaper than the hospitals buy, even though we're on novation. But just because we buy a smaller range of products, and we can bring that expertise and contribution to the partnership. We've been to the rodeo before, and it's important that everybody understands what we can bring. The physicians understand what they can bring, and not only just in terms of cases, but how they're going to expect the flow in the operating rooms to be. That's very, very important because everybody needs to bring what they know and their knowledge to the table, and it needs to be respected by all so that we can go quickly and fast. Next slide. We need to orient the hospital management typically to the ASC trends, particularly reimbursement and regulatory ones. Those are important. They're different than HOPD, which are hospital-based outpatient surgery issues. There really are, again, different animals because there are different requirements being in a hospital versus being in a freestanding center. Joint ventures are typically freestanding centers. They are not using the hospital provider number. They have their own provider number, Medicare provider number. They have their own tax ID number. They're typically set up in most states as LLCs. We work in 15 different states. Often the only one that in Texas we use a LP because of some specific tax laws in Texas. So when these are being set up, one of the things we have to do is look at very carefully the type, the state we're in, and what kind of structure we're going to use. In Georgia, we use a different kind of structure, again, allowing ourselves to take best advantage of tax laws for the partners all involved. There's also differences in processing and processes, streamlining, and efficiency. They are not the same processes that a hospital uses. They're different ones. All the processes used in a surgery center meet Medicare accreditation standards, but they're not as heavily regulated as hospitals are because the patients are different. They don't require the same kinds of processes, and frankly, it's a small business. If you try to lay those processes on a small business, it becomes very cumbersome in both in terms of decision making and also very expensive. So we really need to understand that this is a different animal, though related, and the efficiencies that you really want to get out of them are best preserved if we all understand what the differences are and go with the tried and true. This is not a rocket science thing. It's been since 1982. Surgery centers have had Medicare approval. They've been certified by Medicare, and there are over 5,000 surgery centers in the country. So there are tried and true processes that are efficient, and you want to replicate those and not try to impose heavier burdens on a small business, particularly with the smaller reimbursement we get. There's typically a 40 to 50% difference in reimbursement, again, depending upon the states that we're in, between a hospital-based center, which has hospital rates, versus a freestanding center. The safety protocols are all outlined in Medicare and in accreditation, so they're all there. But again, they're not as burdensome as most of the hospitals have to do because of different regulatory requirements that hospitals have. Again, it's a different kind of business. Next, we need to discuss these with the physicians too. I say hospital management, but it's also with the physicians, because there's differences in staffing ratios, the kinds of people that we're using. We do use RNs, we do use LPNs or LVNs depending upon the state. The salaries are different because the structure is different. This is a 8 to 7:30 starting in the morning surgeries to 5:30, 6 o'clock closing at night. Sometimes open on Saturdays, not that often. People come in and leave at 3 o'clock a lot of times. A lot of these surgery centers are very attractive to working mothers that want to go home and pick up their kids later on. We do use a lot of part-time people or permanent part-time people, so that the salaries and the staffing are quite different from hospitals, even though hospitals do use PRN and whatever. But our working hours are different, and our costs are different. So the salaries and reimbursements different. So the salaries tend to be a little bit different and lower than what hospitals are paying their nurses, though competitive. Benefits are typically competitive because we use either a professional employer organization, and we typically don't camp onto the richer benefits that hospitals have. So typically the joint venture does not use the hospital benefit structure because it's typically too expensive to impose on the cost structure of a surgery center. We typically use a professional employer organization, or in our case we have developing our own PEO for all of our centers and our management staff to have a large group plan, but tailored with employee handbook to surgery center requirements. Purchase services are different. We don't use as many purchase services and maintenance contracts as hospitals do. We have equipment, and certainly those are serviced properly, but we are very careful with that. One of the first things we do when we do turn around a center is go after the purchase service contracts. Typically, there's lots of them, and lots of them are not necessary. The purchase services and maintenance contracts are very expensive. You need them. You need the right ones at the right level of service, but full-blown purchase service contracts, particularly from vendors, are not necessarily the way to go. And we have contracted with a couple of companies that amass the contract services together, blending all 30 of our centers and allowing us to get a discount on those, but still having the backup of the company in terms of replacement equipment, those kinds of things, and recall. Policies are different. They're streamlined. Payer contracts and reimbursement are completely different. Carve-outs for specific specialties. The reimbursement in terms of implants. Payer contracts and reimbursement is a completely different animal. Typically on the joint ventures, we work with the managed care department of a hospital or a larger physician group practice that has relationships in the community with those payers. That helps a lot. Doing it together and in partnership is one of the biggest things the hospitals are able to bring to the table. They have reputation. They're able to help us with the credit rating on our credit lines, and I'll go into that in a minute regarding banking. But the payer contracts and the relationships with the payers are very critical. But that is done together, but the reimbursement is quite different. Business office operations and cash management is completely different, and we'll go into that in more detail as well. Next slide, please. We want to make sure that when we get into the decision-making processes, particularly on the development of a joint venture or management of a turnaround, that is becoming more common. There's a lot of HOPDs that are being converted to freestanding centers to allow the hospital to have a more cost-effective outpatient surgery delivery vehicle for the ACO products that they're putting together for large third-party administrators, self-insured employers, and workers' comp carriers. When that occurs and the transition process is going through, you need to really be able to make decisions efficiently and quickly for best results. That has to be really discussed on the front end. The second guessing is very difficult. We have one client right now. It takes them 2 to 3 months to make a decision. It's very annoying to the surgeons who are very quick in terms of being able to make decisions because they have their own practices. It's hard for us because it extends the process in an unduly long period of time. It just drags the whole thing down. It's very important that we understand, and on the front end, we actually work into some of the contracts a 10-day window, 10 working day, 2-week window for all parties to review something. There's a deadline as to make the decision. The vote is counted, and we move forward. If they don't respond in 10 days, we will typically move forward because we've been to the rodeo before. We know it needs to be done. We certainly want the input because each of these centers are different. They're not like the Burger King where fries are on the left and drinks are on the right. They are tailored to the mores in the medical community. I'll give you an example. You have, for example, in different areas you have different front-end deposits on cash collected up front. In some areas, in more rural areas, it's a lesser amount. In more urban areas where there's more typically affluence, it can be higher. Cash reserves are another area where, when you start building up cash and collections, how long do you want to hold it until you do distributions? Those are things that need to be discussed, and those are need to be done in a quick and efficient manner. Collections and deposits, as I talked about. The way we add new physicians and how quickly we can bring them in versus a very long credentialing processes that many hospitals have, or conflicts of interest by physicians on credentialing committees that don't want their competition to come in when in fact that competition is good for the surgery center in terms of bringing that doctor in. Surgery centers make money when physicians' competitions walk through the front door and do cases on behalf at the surgery center that generates more revenue for the pot. So it's different. You want to make sure that these processes are quick, efficient, and being able to go through in a measured manner, but without being extracted in too long a time frame. Next slide, please. Yeah. Lesson 2, come to clear agreement on the reasons for the project, the goals and objectives, and the timeline. Physicians and hospitals may want different things, and we need to agree on those at the beginning. Next slide. Physicians typically want an efficient place to work, the flow, and good scheduling of their operating room time. They want revenue and profit and cash distributions as soon as possible. Patient satisfaction is important. I say payer satisfaction is becoming even more important. Not more important than patient satisfaction, but more important than it was, say, in past years. Because they're driving more patients to surgery centers now to keep the costs down. Physicians want control on the operating room flow and the experience. They want control on the persons in the operating room. They want control on the equipment selection because that's what the tools that they work with every day. These are important aspects to why many physicians want a surgery center in the first place and want a joint venture. in the first place. Next slide. Separately, hospitals typically want the lower cost to be attractive to the payers. That's why so many of these are converting to freestanding. A bonding vehicle with your physicians, a means of freeing up the big OR for more profitable hospital cases, and more net profit. Next slide, please. The impediments to some of the success of these joint ventures is sometimes the hospital bottom line drives the venture rather than a true partnership. Let me give you an example. It's a pitfall. It's a common one. A lot of hospitals employ physicians now and surgical groups. We have 2 hospital systems, rather large, that will not allow their employed surgeons to work in the surgery center, to the consternation of the other physician partners that are also on the medical staff of that same hospital. The bottom line of the hospital in these 2 particular cases are driving the partnership, and it really is alienating their physician partners greatly. That's not true with most of the hospitals we work with, but it's some of these impediments. I'm bringing up a pitfall that we are finding more common, particularly with the employment of surgical groups. Some of the hospitals won't let go of certain service lines or procedures that are commonly done now in surgery centers versus, for example, spine or retina or GI cases. They've invested in a GI lab. I'm thinking of a particular case in Illinois where the hospital spent some money on a GI lab. Another one in California just similarly we just worked on about 6 months ago. We converted part of the GI lab to a freestanding center, and part of the GI lab on other days works as a hospital. It's a split center. It's able to be done because Medicare allows this to be done. You have to look at state licensing laws as well, but it's in California and the other state, both is able to be done. In this particular case, the reason the freestanding center became in the same space became a viable option was the payers stopped paying, the large payers stopped paying HOPD rates for GI cases, and basically forced the hospital to give that service up. It would have been much better had they been able to do it on the front end. We were able to work through that with the hospital to come up with this split center using the same space. Also, and on the physician side, some physicians, again, depending upon their training and their age, don't want to leave the hospital. Some are very conservative. Even though more and more of these cases, like spine cases, kyphoplasties, some general surgery, are being done safely in many freestanding surgery centers in the United States. So the bottom lines of both the practices and the hospital need to be respected, but at the same time, if you're going to have a true partnership and you want to have a healthy joint venture, you want to put the right things in the joint venture and not starve it for reasons that are outside of the bottom line of the surgery center. Next slide, please. Lesson 3, clear understanding of the timing. This is probably the biggest consternation of most hospitals and doctors. We've just opened 3 centers in the last 6 months. It's taking 6 to 7 months now just to get Medicare after you open. And you have to be ready to open with equipment being there and staff being there, skeletal crew as it may be. It used to take 3 to 4 months, sometimes 2, depending upon the state. If you're going to go have licensing, that's another exam. So there's usually a Medicare exam, a accreditation exam. Sometimes it can be combined, but then they have to come back, and then a licensing exam if you have licensing. In California, with the budget crisis we had a couple of years ago, they don't have anybody to come inspect and license, so we don't have licensing. So the state adheres to Medicare and accreditation standards, and you can open up without a license. In other states like Illinois, you have to go through licensing processes. But these take time. They take time after you're open, after you've equipped the center, after you've built the center. So the cash flow issues are significant. everybody needs to understand the timing of these things. We can't even begin billing until we get a Medicare number, and that's typically, again, 3 to 4, sometimes 5 months after the Medicare inspection. So there needs to be a clear understanding of the timing by all, which is why the credit lines are getting are being asked for on a much larger number to be able to float this time between the time that you actually have equipped the center, staffed the center, and have the processes done until you can actually start billing and collection. Next slide. This slide goes back to the same point. The paperwork needs to be filed ahead of time. Then the inspections occur. Again, either 3 if you're doing licensing, Medicare certification, and accreditation. Sometimes 2 if you combine it, like the AAA, you can get a combined Medicare and accreditation process. But these take time, and you must build in the cash flow and timing expectations to all. You can't even bill until after you get the Medicare number, which typically occurs, again, 3 to 4, 5 months after the Medicare number, after the Medicare inspection, excuse me. These apply to both HOPD conversions. Just because you had one doesn't mean it's going to be rolled over very easily. We went through that with 2 health systems. It's taken 6 months in California just to get it from HOPD when they were generating revenue to now they have to stop, become a freestanding center, and then get the Medicare process done all over from scratch. They don't roll over. And so there's a misconception a lot of times. We made sure there wasn't one in this particular case, but the timing is excruciating because you've been operating for a while. The doctors have been operating in that HOPD for 4 or 5 years, and now they have to stop. They're going to keep working at the hospital to make sure that the hospital gets reimbursed while we're waiting for the surgery center to really start. So the timing is really important, and everybody needs to understand that, and that's why the cash flow, particularly the credit lines, are being extended. Next slide, please. So just to illustrate the point, planning for the cash flow, building a healthy credit line, building that into the financial projections, and getting all partners on board for the timing it takes to do this. Next slide. Lesson 4. I'll go a little bit faster because I think these points are going to be much clearer from here on out. The accounting, typically the best thing to do here is to have the CPAs that are selected to do the accounting for the freestanding separate business in the hospital. It's got its own provider number, tax ID number. We sit down with the CFOs of the hospital and with the physician leadership, and we meet with the accountants to go on the front end to go over the reports, reporting format, chart of accounts, to make sure everybody's on the same page. So when the physicians who typically see cash reporting, because that's how their practice is run, and they see, because it's a joint venture, accrual accounting, we have to explain the differences. So there's basically a session to make sure that when people are looking at the financials, they understand and appreciate what they're looking at and understand it. The chart of accounts is very important so people know in what category what expenses go into. We typically use a standard chart of accounts that most surgery centers use in the United States so we can compare with each other on a similar basis. We use the general ledger to break out particular issues like implants and other kinds of things, but the chart of accounts is important. The banking and the handling of the banking relationships is critical, particularly on the credit lines and equipment leases. We typically don't use cash and raise cash for the equipment. You want to leverage the center. Typically, if the hospital is involved, there's 20% cash down for the business. So I'm not talking about the real estate part now, just the business part. Real estate is typically either owned by a hospital medical office building or a freestanding medical office building or a physician's office, and it's leased by the center at some rate plus common area maintenance charges. But in the business itself, there's a credit line to carry the front-end costs while waiting for Medicare. It's typically used for the first 12 to 18 months, depending on how long it takes for Medicare to come out and get the inspection so you can start billing and collecting. The credit line used to be like $500,000. Now we do $1.2 million to $1.5 million, depending upon the size of the center and the anticipated caseloads and the state in terms of how long it typically takes them to license or Medicare certify a center. These banking relationships are critical. Typically, when we do the joint venture, there is a buy-in by the physicians. We call it the surgery center special. We go to the bank, several, we shop it, and say, look, what we want you to do is to the surgery center and the hospital as providers under compliance cannot loan money to physician investors, but the bank can. So we get the bank to loan the buy-in. Say it's $15,000 a share and the doctor wants to buy 3 shares and they want to put in $45,000. Well, they can borrow that from our selected bank on the surgery center special. Typically, the rate is a decent rate because it's the private banking division, which we typically try to work with the local bank. They're all local banks, by the way. Keep the money in the town. Don't be a mining company and take it out. And the terms are for the first year interest only because it takes a while for the business to get running and get billing out and collections, and then pay it out over 3 years. It allows younger physicians that are coming into practice that already have a lot of debt from their medical education or buying a house or setting up their practice to buy in. It also allows other people that have different physicians at different ages to buy in over a period of time, legally, appropriately, and within compliance. The financial processes of the business office are different, and there needs to be a clear understanding of that. The controller or the CFO of the hospital needs to understand that there's cash controls, there's controls on contractual allowance, there's quarterly updating on that the computer systems selected, typically there's 3 or 4 that are very commonly used in surgery centers, have those controls in them, but they have to be monitored both by the management company or management administrator as well as the accountants on a routine basis. Next slide. The differences in financial cultures, typically the physicians want to maximize the distributions. That's done because you are leveraging and not using cash for the equipment. You're typically doing an equipment line with either the bank or a Siemens or somebody like that typically does equipment lines between a 5 to 7 year amortization, again, depending upon the size of the size of the center in terms of the equipment it requires, as well as the size of the volume that you're expecting, because that'll have to do a lot with the ramp up and the cash flow of the center. So when you are able to leverage the equipment, you're not using a lot of cash. You want to be able to generate additional profit sooner and try to get that back to the physicians as well as the hospital investors. Hospital may want, and typically because of the costs are larger to the hospital, they want to reserve more cash. They typically want 3 months worth of the monthly expenses, where in the beginning we typically do two months in a surgery center and then 1 month after 1 year, because we don't have the hiccups or the, I shouldn't say hiccups so much, but is the unexpected financial waivers that we get with typically in hospitals, where there's a larger amount of money being expended every year, and the variances in reimbursements are great given the fact that they have more types of services. It's a more volatile business. Surgery centers are typically, once it gets started, we pretty much know the caseloads, know the physicians, and it's a pretty standard process of managing it, so there's not as much variability typically in a surgery center unless there's a major shakeup with an acquisition of a group of physicians leaving. They're typically much more stable businesses, and therefore the cash reserves are typically a little bit less than the larger hospital. Next slide. Typically ASCs distribute within the first 16 months. Some break even sooner, but I'd say it was, in our experience, mostly within the first 16 months. Some sooner, some later. Very few later than 16 months. The first 12 months, again, we keep 2 to 3 months worth of expenses in reserve depending on the cash flow. 1 month after the first year. Again, equipment is typically paid off an equipment line, and again, it depends on the financial size and the volume of cases expected. The more cases, typically the faster, and more doctors involved, typically the faster to start up and less borrowed from the credit line, and the cash distribution is faster. There's a strong incentive for all to do more cases as soon as possible. Next one, lesson 5. It's very important with the physician leadership in the hospital to review the budget assumptions. Go over this carefully. Some vary from the original projections. Typically, the projections are done based on interviews with physicians, but once the partnership is formed and the actual physicians that are going to come into the project are identified, typically we rerun the financials, and some of the physicians that originally said they were interested may not participate in the joint venture. Payers' reimbursement also changes over the years. It could be up to a year or 2 years from the time the projections were made, so the budget is redone typically right before the opening of the center, before the Medicare, so we have a new budget that's more realistic based on what we really expect from the physicians that are going to participate, and that we have a better idea on the reimbursements, period. Typically, also, within the first 3 months after you get the Medicare certification, and when you start doing some cases, it might also be revisited. We're doing that actually on Wednesday with our newest center in North Carolina. It's been a slower ramp up, mainly because of the length of time for the Medicare to come in, and as a result, we've restructured the budget so that it's realistic for everybody. There's no sense in using something a target that nobody's going to meet given the realities of the situation. Not that the physicians are not engaged, not that the hospital is not engaged, and they've been extremely supportive, but it's just taking longer time than we all anticipated to get the Medicare and the licensing to come out in that particular state to get the place really open and be able to bill. Financial losses during the first year, the ramp up is incredible. You don't want to pay all the debt down at first. You want to use the leverage, as I said, and be able to pay some distribution as soon as you can. There's a real psychological benefit. It could be $500. It's just really important to allow that debt to be structured so that there is, like the equipment debt or the credit line debt, you're not going to pay it off before you do distributions, typically. There's a tendency to want to do that and get out of debt, but that's not a smart way to manage a successful and healthy joint venture. You want to get some money in the doctor's and the hospital's pocket to prime the pump, to make sure people that know that may have been people that waited, particularly people being physicians, that waited to get in the partnership to see if it really is going to take off or not. And the fact that there's some kind of distribution and the doctor's walking the lounge with a check in his pocket is a big deal. So again, the debt and equity part and using the debt properly, structured so that we know it's going to get paid. It's going to get paid in the proper time frame, but not burning up all the cash and not keeping enough to get some contribution back to the investors is important. Next slide, please. I think we've already gone through this. We've got to get everybody accustomed to the accrual accounting, cash format versus accrual, and that's important because, again, the physicians use cash in their practices, and the cash reserves we talked about are important. This is also important because typically the first 3 or 4 months we're out of network. We can't get the contracts until we get the Medicare numbers. You can't button those up. And though before we open we're talking to the payers, they typically don't want to sign a contract or even sometimes negotiate rates until you get the Medicare numbers. So because of the out of network with the first several months, we have higher fees And the accrual accounting is going to have contractual allowance, which we need to explain to most of the physicians, because again, they don't typically see that. They're looking at a cash statement. It's already taken out before they see their bottom line typically from their accountants. But we have to get everybody used to understanding that because we're out of network, we're going to have very large contractual allowance at the beginning, and then the rates typically get adjusted once we have the contracts in place so that we're not sticking out with very high fees. Lesson 6, and I'm just about finished. Majority shareholder and control. Next slide. There is a significant difference between if the hospital owns 51% versus the physicians. They have to, because of compliance reasons and tax reasons, not compliance, compliance with nonprofit reasons, have control on no debt done without consent, consent to change or move the business, future partners. Those are issues that minority owners of the physicians want to retain control on if the hospital owns 51%. Next slide. If the physicians have majority shares, the hospital needs specific nonprofit controls on accounting to protect their status, charity care, that's typically within the operating agreement, Medi-Cal and Medicare, I call it Medi-Cal, but it's Medi-Cal in California, Medicaid everywhere else. My California bias here, excuse us. And care to underserved while we're maintaining a profit. And you can manage the Medi-Cal, Medicare, and Medicaid processes, but you need to typically have it if you're doing a joint venture with a hospital. There's ways to control that. The control differences between ownership and control are significant. Just because you own 51% doesn't mean necessarily you control all the operations. The hospital, if they own 51%, has to have physicians that are minority shareholders having control of these particular areas we talked about earlier. What kind of new partners you're going to have. Who's going to come on and how we're going to get physicians that are deadwood out of the partnership. Those are outlined in the operating agreement. Those need to be adhered to. Typically, the management company turns out having to be the bad guy, which is fine, because the hospital needs to maintain relationships with its physicians. The partners want to retain relationship with their peers, but somebody's got to do it. And you've got to get the dead word out, particularly if they've committed to being a partner and not being participating. Typically, these operating agreements have 2/3 consent from all partners on specific issues that are related to what we call the major issues of control in a center. Next slide, please. So in the operating agreement, which is really what runs the LLC, if it's a partnership, it's a partnership agreement. If it's an LLC, it's an operating agreement. These ownership and control differences are outlined. It outlines the rights of minority and majority shareholders. The ownership eligibility. Do they have to be a physician? Can outside entities own it? What kind of caseloads do they have to do to be active medical staff, which then allows them to be part of the partnership? You can't throw people out because they're not doing cases. That's illegal. But in the medical bylaws, it typically defines what an active medical staff member must do to remain active on the medical staff. And that typically crosswalks back to an operating agreement that says you have to be an active medical staff member to be a partner. So these are important nuances in the operating agreement that relate to ownership eligibility and being able to get deadwood out. The drafting of these operating agreements shouldn't be done by your uncle's attorney. It needs to be done by an attorney that does a lot of surgery centers, not just 5. There are nuances and changes that are very beneficial to joint ventures in the language of the partnerships, in the language of the operating agreements for these LLCs that are typically done by law firms that do them on a routine basis and then stay up on the nuances of surgery centers. Partnership buyout and buy-in. Again, that needs to be very clearly defined on the front end, agreed to, and it needs to be articulated. And the main thing is it needs to be enforced, in a legal and ethical manner. There's a psychological misstep here. Writing the partners, I should say, it should be really in terms of taking the partners out of ridding the partners from that are deadwood. There are particular ways to do this. Peer pressure is particularly one, but in the operating agreement, again, there needs to be these active member crosswalks back to the operating agreement that are very important. You want to be able to get the deadwood out, particularly if they're not going to participate, but there's a proper legal and appropriate way to do that. Next slide. The lesson 7 is to make agreements on physician recruiting and adding services. For example, we don't want to disallow employed physicians to use the center just to protect the bottom line. They want to be able to add physicians and services. Next slide. You want to be able to, next slide. You want to be able to attract, move particularly appropriate services to the ASC to attract payers, reduce patient out-of-pocket costs, and give patient more satisfying experience at the center. Next slide. Because of the time, I basically just reiterated the 6 traits, which you all can see on your slideshow. I'm not going to go through these all. They kind of reinforce all of the points I've already made, so I had not planned to review each of these with you, but mainly we'll put there to reinforce some of the points that we made earlier. In ending, I think the main points are clarity of purpose, making sure everybody's on the same page, being sure that the financial parameters of the center are clearly understood, the budgets are revisited, they are realistic, the expectation levels in terms of decision making are very clear, and that we're able to work together on a respected basis based on everybody's expertise and what everybody's bringing to the table. With that, I'll close and allow for questions for anybody that would like to pose them. Thank you for allowing me to share some of my thoughts with you this morning.
Robert, thank you for a very informative and enjoyable presentation. We will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and then clicking Send. Our presenter will attempt to answer as many questions as he can during the time we have for Q&A, and will follow up on questions he does not have the opportunity to address. Okay. Robert, an audience member would like to know, what are the biggest pitfalls for a hospital positioning a joint venture?
I think the largest pitfalls are exaggerated expectations by all that there may be profitability sooner than the process normally takes. I tried to emphasize that during the presentation. By the time you've thought about this center, it gets organized, sometimes built or possibly renovated, or even if it's a HOPD conversion, the time it takes to get through the regulatory Medicare accreditation and legal processes take time. And then after that, the Medicare is taking so much longer now. So the expectations of timing is very important, and as a result, the projections and budgets are being recalculated, and again, the cash flow and credit lines are being extended because of these. I think that's really, of the last 3 we've developed, that's been the biggest issue to address. They've been addressed, but they're very frustrating to everybody. I call it pitfall only because it's one that everybody has to be acknowledge, and it can be very disruptive to the partnership if everybody doesn't understand it and be patient with it.
Thank you. Okay, we have another question. How do bundled payments fit into hospital and physician joint ventures?
We've been working on that for the last, actually, 3 years, particularly on our spine program. We put together a program with the hospital in San Diego. They have a very robust inpatient spine program, PMR, physical medicine and rehab program, and we had the surgery center across the parking lot. With the outpatient spine procedures moving for many disectomies, spine disectomies, ACDS, those kinds of procedures that are moving out, even trials on spine stimulators. We put together a program for Blue Cross of California. They're separate in the state, Blue Shield and Blue Cross of California, to combine what the hospital had with what the patient, the outpatient surgery had, with a bundled rate for outpatient surgery, which would include the physician, the MRI at the hospital, the CT at the hospital, the professional fee of the surgeon, the anesthesiology fee, the post-surgical physical therapy, and put that in a bundled rate. We came up with a cash price because in San Diego we also had people that were coming in from Mexico that were just paid cash for it, but also we had some people that were not covered that wanted these particular neurosurgeons that had a particularly good national reputation to be able to pay if they came in from out of state and didn't have Blue Cross, for example. Then with the Blue Cross payer, they wanted a bundled rate, and we did that. The computer system of Blue Cross actually could not handle a bundled rate, and a lot of systems can't, but we can adhere to a dollar amount that we agreed to, even though we have to bill it the old-fashioned way. But it's a very, very interesting discussion with the hospital CFO, COO, and CEO, of course, along with the surgeons, and more of that's occurring right now, particularly on these very expensive procedures. We're seeing a lot of TPAs, third-party administrators, that represent large self-insured employers that have, for example, let's just take a company, I'll say Sears, although it's not Sears. They have a Blue Cross plan, a Blue Shield plan for their employees, but they found that 18 CPT codes are the most expensive for them, and they're really getting a lot of expense related to those. So they carved those out of the healthcare benefit plan and looked for a partner in a surgery center and neurosurgeons and orthospine surgeons, pain management physicians, and PMR doctors to bundle something to keep the costs down. So we saw what their rates that they were getting paid on EOBs were at the hospital. We came up, we know what we're getting paid with surgery centers, which was not much, particularly since Medicare doesn't pay a lot and some of the payers don't pay a lot for outpatient surgery unless you're, spine surgery, unless you're out of network. And somewhere in between, we came up with some bundled rates, and that's what's occurring more and more often, to go back to these large self-insured employers through their TPA to make it attractive for them to take that out of the hospital and put it into a joint venture owned by the hospital and the doctors to be more cost effective and with good results, medical results. That's the process we're going through right now with several of our surgery centers at this time to respond to 3 large TPAs, national TPAs who we've contracted with at different rates, two of which have bundled rates, the other of which is basically negotiated fee for service for all entities.
Perfect. Thanks, Robert. We have another question from an audience member. How could an ASC motivate their hospital partner to be an active partner in negotiating payer contracts?
Well, I think that the outside, the third-party payers, the insurance companies are all asking for this, and they're asking the surgeons for this, they're asking the surgery centers for this, and we're basically we have one center like this right now, where again, it's a bottom line protection thing, and we went back to the payers and basically have letters from a very, very large payer in Southern California saying to the hospital, look, we know you've got this delivery vehicle that's very cost effective. You really need to use it. And to the extent that the hospital did not, the large medical group ceased doing all their GI cases at the HOPD. Now that was a severe example, but it actually happened. And as a result, they formed the joint venture, and we're now doing all those GI cases predominantly back in the surgery center that they were doing them. But it's going to be the payer and the outside TPAs and self-insured companies are going to drive that. But I think the ASD management, ASC's management must reflect what the outside payers are demanding, because one way or the other, they're either going to go there or they're going to go somewhere else. And the hospital's going to, and the doctor's going to lose market share if they don't service the payers properly. Any other questions on that? Hello?
Hello?
Yep, I'm still here.
Hi there. One moment, please, as our moderator is having some technical difficulty. We'll be asking the next question in just a minute.
Thank you.
Alrighty, for the next question here, we have a question from the audience that says, does Medicare make sense in an ASC? And if so, what types of specialties do you look for to be profitable?
Ophthalmology makes sense. The vascular access makes sense. Some of the urology procedures make sense, particularly if you do lithotripsy. On general surgery, it's very tough, other than small, access type issues. It's very difficult on orthopedics because Medicare does not pay for implants, and as a result, it's very difficult to make profit on orthopedics. The GI obviously does, because it's a low-cost procedure, and if you have a good volume, it's okay. Those would be the specialties that we would look for to do Medicare on in an outpatient surgery center. The other specialties, obviously cosmetic surgery doesn't apply. Orthopedics is not good, and some of these other vascular surgery, other than the accesses, does not lend itself well. But those would be the specialties that we focus on if we're going to do Medicare in a center. And we do apply, by the way, for Medicare and Medicaid for all of our centers. Again, we have to manage that process, and then we manage that through our physicians' referrals, because we're supposed to take Medicaid patients if they present themselves, but and we do, because it's law. But you got to be able to manage that with your physicians in terms of both Medicare and Medicaid payer mix. Payer mix is very key to the profitability of the surgery center, as which was the thrust of the question. But those are the specialties that you can make money on.
Thank you, Robert. Those are all the questions we have time for today. I want to thank you again for your excellent presentation and for all of you for participating today. We look forward to having you join us for future webinars.
Emily, just real quickly, if there's a question, my email, I think, is on one of these slides, and I'd be happy to answer any, yeah, there it is right there. I'd be happy to answer any questions that come up afterwards via email.
Absolutely. Thank you, Robert. This concludes today's program, and have a wonderful afternoon.
Thank you all for your time.